Hello everyone, so now we've seen the tableside choreography, so very important to the effective performance of RAVR. Now sometimes, particularly in younger patients, mechanical valves may actually be the best prosthesis for the long-term survival and lifetime management of patients with bicuspid or tricuspid disease. So let's have a look in this episode of RAVR using mechanical replacements. Well, now we've seen a bioprosthetic RAVR. Let's look at a younger patient. This is a 55-year-old gentleman who has severe bicuspid aortic stenosis with mild aortic insufficiency. The ascending aorta is clamped and the aortotomy is commenced. Initial inspection, making sure we're at the level of the left main ostia in a correct position, then the aortotomy is taken down towards the midpoint of the non-coronary sinus. And we can start to see the severely stenosed bicuspid valve. And you can see the fused raphe between the right and non. Sharp dissection is taken using the robotic curved scissors. I get asked many times of, do we need a rongeur? Of the well over 350 cases now we've done since we've developed the RAVR approach, we have never had to use the rongeurs. The curved robotic scissors are excellent in its ability and strength to do a meticulous debridement of the entire annulus, including cases with complex calcium. But it's important to do suction aspiration of any and all particulate matter, which we will do momentarily. Getting complete decalcification of the entire annulus, and sometimes required is the entire aortic root. This sort of scissoring motion you can see us use is sometimes required when the tissues are very thick or there's a lot of calcium. Now to the left coronary, we can start to see the annular calcium there. It's very important to get behind the annular calcium to get a nice, beautiful, homogeneous plane, as you can see developing here, which we would do in open cases, and nothing should be any different in a robotic approach. So here's the removal of the bicuspid valve. After copious irrigation and complete decalcification of any matter, we'll now commence with the suture placement, starting at the left non-commissure. And again, moving clockwise with good full thickness placement, needles perpendicular to the tissue. And as discussed before, once we're at the midpoint of the right and or 12 o'clock on the clock face, I tend to utilize my left hand to place the sutures. This allows for ease of motion and coordination with your tableside associate while keeping the camera central to your field and coaxial with the aortic orifice. We'll now size the annulus. This is sized to a 25 millimeter mechanical prosthesis, which is then prepared tableside and lowered through the wound. In this case, of course, taken off the holder and slipped through the incision, and now lowered very carefully into place. This is very important at this point, is to use your needle driver to just negotiate the aorta so it slides through the sinuses and onto the annulus in a seamless manner. And then suture fastening first with the nadirs and then circumferentially until completion. And you can see the really excellent visualization all the way down to the midpoint of the left ventricle through the valve prosthesis, and we have Excellent motion. And then we will now close the aortotomy using the techniques we illustrated earlier. The aorta is a little on the thin side today, so we were going to use careful sutures here. But this is somewhat relatively common in bicuspid disease to have thin aortas. This patient did not have an ascending aortic dilatation. The first suture is secured. I like to go through with my second horizontal mattress bite through the actual pledget just for added security. And on the opposite side. After the first bite, we will now proceed with the usual horizontal mattress. To bring the edges of the aorta together in a nice homogeneous fashion. Okay, and now as the first part of the aortotomy is closed, we'll pass the suture back and then use the long tip forceps to provide counter traction when possible. In this case, we're using it to retract the right ventricle to get best exposure, but that's also a move that we can do. And then completing the second layer with consistent precision. Once that's done, the suture is brought laterally and posteriorly through the working incision to start the opposing side medially. The pledgeted stitch is brought down and secured. Grasping one end, it allows us to create a nice horizontal mattress. We'll turn the vents off at this point. To get nice aortic opposition. And then traction and counter traction between your DeBakey and needle driver, so we don't have any purse stringing with this first horizontal mattress layer, and then proceeding to run this little locking bite at the origination. And then a running over and over suture over the horizontal mattress suture for the second layer. These follow surgical principles for aortotomy closure. And then the final closure, followed by delivery of antegrade to make sure we're in a good spot, which we are. Small little needle holes, but that'll stop very quickly with protamine. And the patient is reanimated and weaned off bypass with a single chest tube with an excellent hemodynamic result with a mean gradient of 8. So let's take a look at another example of severe aortic stenosis, again bicuspid, and this patient is 61 years old, but with a bicuspid aortic valve, presenting with severe aortic stenosis. And we're illustrating this because many patients want to have this done only once. Looking at this bicuspid valve, this is another example of why transcatheter therapies in bicuspid valves that are heavily calcified are perhaps not ideal, as imagine all of this calcium having to be pushed to the side with a TAVR. Now, many of our transcatheter colleagues and heart team members, of which I am a card-carrying member, we take a look at the CT scans and the calcium scores, and this patient would likely be not an ideal candidate. But this demonstrates the severe burden of, in this case, leaflet and some degree annular calcium that I'm kind of debriding right now. So we can get a beautiful, homogeneous, smooth debridement of all calcific material. And following irrigation, we will now place the valve stitches as we've demonstrated previously. And then following placement of the corneosteal catheters and cardioplegia, we placed the valves through the soaring ring. And this is a 23 millimeter mechanical prosthesis being lowered into place. Suture fastener is placed, and that concludes our mechanical RAVR. Aortotomy now closed in a very similar fashion that you've already just seen. Now, aortotomy closure takes approximately 20 minutes. As we start to go through the learning curve, it can start a little longer than that as you begin these procedures, but I think your target should be 20 minutes. That is, should you choose to do a horizontal mattress procedure, which I would recommend. Now, these procedures, overall, now you've seen a standard bioprosthesis and 2 standard mechanical prostheses procedures. These take approximately 3 hours skin to skin after you've crested your learning curve. Our patients, as you've seen in the previous videos, are oftentimes, if not always, extubated in the operating room for elective procedures. The aortotomy is now tested here, and the patient weaned from cardiopulmonary bypass after reanimation. A single chest tube is placed and skin reapproximated, and here's our final result. These have become very routine procedures.
So now we've seen how to perform a mechanical RAVR. As we build upon what we've seen so far, we've seen straightforward pathologies for tissue valves and mechanical valves. So join us in our next episode where we're going to take the step further and approach patients with more complex anatomy and heavy calcific disease, particularly in bicuspid, and even involving the left ventricular outflow tract.